Welcome to Ra Online. Today's topic is oocyte retrieval. Steptoe and Edwards, they retrieved oocytes by laparoscopy for their first in vitro fertilization in 1978. Now this oocyte cumulus complex, which was aspirated from the growing graphene follicle, is more likely to be aspirated when the follicle is near collapse. So to monitor the growth and near collapse status of graphene follicle, ultrasound as done by transvaginal with color Doppler is better than laparoscopic camera guided procedure. So these days, even though Edward and Steptoe retrieved their oocyte with laparoscopy, these days all oocyte retrieval is done with the help of transvaginal ultrasound. What are the indications for IVF? We have some traditional indications. We have when the tube is blocked, and we have the severe oligoacidoteratozoospermia or the male indication. So the female indication for IVF is tubal block and severe oligoacidoteratozoospermia. When we have a surgically retrieved sperm, it should always be used for IVF and not for ICSI. Here we see a transvaginal ultrasound. This is the ovary, this is the cortex of the ovary, and the central part is the medulla of the ovary. Here these are the graphene follicles which have been stimulated, and so this is around a day 6 or day 7 scan when the follicles are growing and multiple follicles are seen. More recent indications of IVF include a woman with ovarian aging, premature ovarian failure, women with unexplained infertility, postmenopausal obstetric women who want to become pregnant, surrogacy, and patients who require pre-implantation genetic diagnosis for autosomal or X-linked disorders. Before starting an IVF cycle, we need to do the baseline hormone profile of TSH, LH, FSH, serum estradiol. We need to do the ovarian reserve markers like antral follicle count and AMH. We need to do the infectious screen on the lady and her husband, including the HIV, the HBS. For the semen, we have to do the semen analysis according to the WHO parameters, look at the semen morphology, look at any pus cells or any microorganism infecting the semen. We also do a hysteroscopy to have a look at the uterine cavity, and we also do endometrial biopsy sometimes to find out if there is any displaced window of implantation. Counseling of a patient for IVF includes what to expect, when to expect, how to go about the procedure, what will be the steps of procedure, what is the success rate expected out of this procedure, what does a clinical expect out of them, a clinician's routine visits are required, and also to explain the patient the individualized success rate based on the various clinical and hormonal profile of the patient. Then we also have to explain the reproductive endocrinology. So what we are seeing here is that with the days of ovulation, there is a rise in the estrogen because of the estrogen being secreted from the granulosa cells of the graphene follicles. So by around 13th day, there is a estradiol plateau, and when this estradiol plateaus, this leads to a LH surge. So luteinizing hormone surge is the one which leads to the final maturation and release of the cumulus euphoricus complex. And after the release of this cumulus euphoricus complex, we see that the graphene follicle turns into the corpus luteum, and after the luteinized follicle now starts secreting progesterone. So the progesterone levels now start rising in the second half of the cycle, and this progesterone rise in the second half of the cycle is meant to support pregnancy. So the value of estradiol, which is around 250 picogram per ml per follicle. The value of progesterone, which goes up in the second half of the cycle, is around 20 nanogram per ml. The value of FSH in milli international units per ml. So there is a mid-cycle FSH surge, okay, and this goes to around 10 to 20 milli international units per ml, whereas the LH surge, which happens in the mid of the cycle, goes to around 150 milli international unit per ml. So now we also have to understand that GnRH is released from the hypothalamus, which acts upon the pituitary. Pituitary has got an FSH secretion in the first half, LH secretion in the second half. The FSH causes the growth of the Graafian follicle, and the Graafian follicle grows as primary follicle, secondary follicle, and there is ovulation from the follicle. After the follicle ovulates, it turns into the corpus luteum, and corpus luteum secretes progesterone under the influence of LH. So, under the influence of estrogen in the first half of the cycle, there is an increase in the tortuosity of the glands, increase in the number of endometrial glands, and increase in the vascularity of the endometrium. Now, this glands which have proliferated in the first half of the cycle, in the pre-ovulatory phase, they undergo secretory changes in the second half of the cycle, and now the vascularity and the thickness and the stromal edema increases much more in the second half of the cycle, and this is what makes it fit for implantation. The endometrium has got the various layers. So, below the endometrium lies a myometrium. The basal layer of endometrium is called stratum basalis, and the superficial layer of endometrium is called as a stratum functionalis. Now, this is an endometrial and ovarian changes. This is the endometrial change, this is the ovarian cycle, and this is the hypothalamus secreting LH, hypothalamus secreting GnRH, which acts upon the pituitary to make it secrete LH and FSH. Choice of protocol for IVF is tailor-made for the patient, and it depends upon the age. The more aged patients require more higher dose of gonadotropins. If the FSH is high, that means her ovarian reserve pool is less and she requires a higher dose. Antral follicle count is more, means she requires a lesser dose. AMH is more, she requires a lesser dose. If she has any pelvic disease or previous pelvic surgery or ovarian surgery or PID, then also the dosage required may be high. Now, earlier days we used to use the standard long protocol, and in this standard long protocol we used to start giving the GnRH agonist from day 21 of the previous cycle, and we used to call the patient on first day of the bleeding or first day of the menstrual cycle. We used to measure her estradiol levels and document it less than 75 picogram per ml. Then from day 2 or day 3 we will start gonadotropins with or without LH addition, and then these FSH administration can be given as a step up or step down or a sequential protocol. And after the giving FSH, we usually monitor the growth of the Graafian follicles in the ultrasound, and we also monitor the estradiol levels and to find out whether the patient is going in for hyperstimulation or the stimulation is going on properly. Now, these days we have stopped using the agonist protocol, we are using only the antagonist protocol. We call the patient on the second day of her periods, that is the time we can even document her estradiol, which should be less than 75 picogram per ml. And the idea for giving antagonist is to prevent this LH peak. We start FSH with or without LH addition. Then we start giving antagonist from day 5 or day 6. And once we start giving antagonist from day 5 to day 6, this mid cycle LH peak is prevented. So, we give the HCG trigger which mimics LH surge ourselves, and just before the oocyte is released into the peritoneal cavity, we aspirate the Graafian follicles ourselves.